like to start with cohort studies, and please feel free to interrupt me whenever you have any question or when my explanation are not clear for you. So it's completely fine. Feel free to interrupt me whenever you would like. Okay, about cohort studies. First of all, I have a question for you. Suppose you're a clinician and you have like 150 breast cancer patients, and you are going to see the recurrence rate or the survival of your patient after 5 years. So from now until 5 years, you are going to check and to see how was the recurrence rate of the disease and how much was the survival of the disease. Which study design you will use? This is a question. Okay, I have another question for you. Suppose you have a population, and in this population, you're going to check the association between, for example, processed meat or red meat. On the other hand, the intake of fish and fish products on the risk of bladder cancer. Which study you will use? Okay, my answer to these two questions are cohort studies. Let's first start with the definition of this type of studies, and then I will provide you with more detail about the benefit of these studies, advantages and disadvantages of these studies, also how to analyze the data from these kind of studies, and finally to compare cohort studies with case control studies. As you see here, a cohort study is a group of people that they are going forward. So actually this is an ancient word, and it came from like a Roman military unit. And as I said, the meaning is about a group of people that are going forward. There are some synonyms for cohort studies: longitudinal studies, prospective studies. We also call them incidence studies and looking forward studies. Here, I would like to ask you a question about, do you remember which study was about prevalence studies? Anyone? Prevalence studies? I'm gonna open chat here. Yes, thank you all. Yeah, for incidence, it's cohort study as I'm showing you here. So for incidence studies, our main study design is cohort study for sure. And how about for prevalence? Yeah, in the previous session, I have covered this one. Cross-sectional study, perfect, great. I mean, in the population at the point of time, okay, they are designed to estimate the frequency of a health event in the population at a point of time or short period of time. Okay, both of them can be the case in cohort studies. I think your question is about cohort studies. So for prevalence studies is cross-sectional studies. So remember this one. I hope you have access to our chat, and you can see I typed some points for you. Okay. Here, what is the main aim of cohort studies? Actually, it is to investigate the association between exposures and health outcomes. This health outcome can be assigned as a disease, or can be also assigned as a relief from a disease, maybe a recovery from a disease. Okay, let's go to the next slide. In the meantime, I'm checking our chat if I have any question. No question from you. Okay, Sorry, you may remember this one. A still cohort study is categorized in observational studies. We have already covered these topics, and yet we have to go forward to cover all these kind of studies. Again, believe me, if I would to teach this course, for each of them, I will go for at least 2 hours for each study design. But if okay, let's proceed. I hope you guys have enough time to read the rest of the studies, maybe delve into them and improve your knowledge about each study design. You remember during the previous meeting, I mentioned several times that please remember this chart. For cohort studies, as you see, this is categorized under the category of individual-based studies, analytical, and non-experimental studies, which is observational study. And here we already covered case control and cross-sectional. Okay, do you remember for cross-sectional studies, I said at the same time, like taking a screenshot or a snapshot, we look at exposure and outcome, as you see here. By the way, can you see clearly my screen, everyone?
Yes, Dr. Ken.
Okay, perfect.
Yeah, thanks.
Thank you. Thanks for clarification. And also I mentioned, if we are going to start from outcome to occurrence, then we will go for a case control study. Do you remember I said we have some breast cancer patients and some healthy controls, and we are going to ask the patients and the control group if they had any previous history of chest X-ray, previous history of, for example, smoking, and so on. How about in cohort studies? In cohort studies, we mainly start with the exposure, and then we will continue to see the outcome of exposure. So let's open this topic a bit more. Let's delve into it. Suppose you are a researcher and you are going to see the effect of smoking on the occurrence of cardiovascular diseases. So here you have smokers and non-smokers. And over maybe a short period of time or a long period of time, it's depend on the disease. You will follow your population to see the occurrence of the disease, these cases, among smokers and non-smokers. And then you will compare the outcomes between these two groups. So as you see, our study is started from exposure, and we are looking forward to seeing outcomes. So we know that cohort study is observational study, and can a group of people, or maybe in sometimes we can include a group of participants from different countries, different continents, to examine how a certain factor, for example, air pollution, for example, exposure to smoking, and so on, can affect individuals' health outcomes. Basically, cohort studies are particularly useful for identifying risk factor for the disease. So if I asked you next time, what is the best study in order to find risk factors for a disease, your answer would be the best study design is a cohort study. So if you want to test a hypothesis about association between an exposure and an outcome, this is the best time to use a cohort study. And also, if you have access to a large pool of research subjects, sometimes cohort studies includes thousands of individuals in their studies, and you have enough time, resource to follow these participants over a long period of time, it's the best time to go for a cohort study. Also, if you would like to measure multiple outcomes or disease or incidence of any outcome over a time period, again, this is the best time to go for a cohort study. Remember my first slide in this presentation. I showed you if you are going to see survival or recurrence of breast cancer in your population, because patients already diagnosed with breast cancer, and if you are going to see recurrence or survival of patients after 5 years, then the best design is cohort study. And also, please remember that if you are going to really look at causality rather than a correlation, do you remember the correlation in ecological studies? We have already mentioned that we see, for example, if the intake of high fat in the society is high and the cardiovascular disease burden is also high. So in this case, we use correlation. However, in cohort studies, we are going for causality. Any question for me?
No, sorry, just ignored it. Yeah.
Sorry,
Yeah,
doctor,
okay.
my grandmother was talking to me just now.
Oh, no worries. It happens. It's okay, completely okay. So let's see the position of this kind of studies in creation of evidence. As you see here, cohort studies are really high ranked in making evidence, and the evidence that are made by cohort studies are really, really high. So just to go for design of cohort studies, basically we start with exposed and non-exposed individuals. And as you know, in the future, we will see if the disease developed or not developed in both groups, both exposed and non-exposed groups. Okay, suppose you had a population and under the affiliation of Stanford University, and you started your study at, for example, 2000. Over the years, you are looking at your population. As you see, all the population here, maybe, as you see, they are not sick. They have no disease, basically the disease of our interest. And they are exposed and non-exposed. Our main exposure here is smoking. So in your city, you are looking at people if they are smokers or not smokers. And over the time, over maybe after 5 years, 10 years, you see the occurrence, let's say the incidence of the disease among exposed people and non-exposed people. I also mentioned this slide in my previous lecture. As you see here, this is about cohort studies, and here is about case control studies. You remember that for case control studies, we had a group of people and they already have a disease, and then we have healthy participants. And then we go to look at their history to see if they had any prior exposure to, for example, smoking or OCP or and so on. But here the story is completely on the other side. We start from exposed and unexposed, and then we see how much is the incidence of this disease among both groups. So in case control studies, you will look at exposures. In cohort studies, you will look at outcomes. Remember, if you see OR in a publication, it's about case control study. If you see RR or HR, it's a cohort study. So basically for cohort studies, we have prospective cohort studies, retrospective cohort studies, and combination of both retrospective and prospective cohort studies. Let me clarify this point by showing you this slide. Suppose in the past, in October 2015, you started a cohort study. And right now we are here. Okay, this cohort started from, for example, 2015, and it has ended in October 2023. So this is retrospective cohort study. However, if your study is going to be a start from now, from October 2023, and then you are going to follow up your population until 2040, this is a prospective cohort study. Okay, let's combine these two types of studies. If you have launched a cohort study in October 2015 and you are going to continue this cohort study over the years, maybe 2040, this is a combination study, combination of retrospective cohort study and prospective cohort study. For any type of cohort study, we are looking at our population if they are going to be sick or not, or if they are going to show any outcome that we are investigating or not. Just I wanted to show you here more clearly. Suppose you have a population, but this is the key point. This is the key point that non-randomized, because you cannot manipulate the exposure. So the population has already been assigned to two groups, exposed and non-exposed group. And then in each category, we will look at the disease. If they are sick, if they got for example, cancer or cardiovascular or not. So the key point here is non-randomized. Try to remember this one because we need it for next presentation, which is about experimental studies. And for retrospective studies, the story is like, for example, right now here, you will go back to see, for example, the medical records, any, for example, questionnaire, any biobank or whatsoever that you have, you will see the exposures, okay, for example, exposure to arsenic, and then you will look at your population. If this person has already been exposed to arsenic, is he or she is right now sick or not? This is a cohort study. So there are some elements about cohort studies that I'm going to cover in this presentation. First of all, about selection of subjects, then obtain data on exposure, selection of a comparison group, follow up and measure outcome and analysis. A key point here is about follow up of your population. So if you're going to launch a cohort study, maybe you can go for general population. Okay, maybe you will go for the population under the affiliation of Stanford University. You can select all the population, or you can go for special groups. For example, you can select the student in your class, doctors, nurses, teachers, employees, or whatsoever. Okay, so you can select a group of special people, let's say nurses here. So you can choose all the nurses at your university and look at their profile right now. And also maybe you can find and you can see a questionnaire and then ask the nurses about if they are frequently doing, for example, night shift work or not. And after 10 years, you can see the effect of night works on the occurrence of diabetes, cardiovascular disease, any type of cancer, and so on. As you see here, the nurses right now, all of them are healthy, but some of them are, doing more night work shift, but the others no. Then you will see after 10 years if they got any disease. So let's go forward here. So basically, in the previous slide, I mentioned if you select a whole population, so it doesn't matter. It is a nurse, lawyer, teacher, student, male, female. It's like starting with a population. All of them are healthy. It means they don't have the outcome of our interest. Here, you will start with the nurses or with a group of people, and you already know if they are having exposure or not. So in order to obtain data for exposure, there are several ways that you can go for. For example, you can perform interviews, questionnaires, you can check their medical records. For example, if they were at the risk of getting, for example, chest X-ray, if they had any kind of surgery, and so on. Also, we can use medical examinations, blood pressure, blood tests, serum cholesterol, EKG, and so on. Or you can also use the environmental surveys, like, for example, if these participants at their workplace, they have exposure to any chemical like arsenic or air pollution, and so on. So as you see, there are several ways in order to obtain data for exposure. So basically, information about exposure will allow classification of cohort members according to whether or not they have exposed to suspected factor. If they are yes or no, and then we will look forward to seeing the occurrence of the disease. If you may remember, I mentioned a key factor in cohort studies is follow-up. In order to do a successful follow-up in your population, it is suggested that you can go for periodical medical examination or review of the records, or maybe routine surveillance of these records. And sometimes you can perform interview, phone call, or maybe you can also visit the participants from their homes, or their home, I mean. And as you see, there are several ways in order to perform your follow-up. However, in some cases, we have lost to follow-up. So I would like to ask you a question. Why lost to follow-up occur? Why we have lost to follow-up in our cohort study? I hope I can hear something from you. Why we have lost to follow-up? So maybe it's a difficult question for you, then I will go forward and I will cover this question also. Okay, not yet. I will go forward. Okay, lost to follow-up, actually, it's a really big issue in cohort studies. And sometimes we have attrition in our population under study. This is really natural. This can happen in any cohort study. So if you are reading a publication and design is cohort study, don't be shocked. Don't be shocked. Loss to follow-up is normal in cohort studies. And this can happen due to death, change of residence, migration, and maybe sometimes they really don't like to continue our study. Okay? They really don't like, because participation in this study is voluntary. So you cannot obligate any individual to stay in your study. So there is no benefit for them. They will decide to just, withdraw from your study. So these are the main reasons for lost to follow-up. And basically in epidemiology, we say achieving about 90 or 95% follow-up is really perfect if we can have it. However, if it's not possible, so maybe we can find really reasonable logic for that. So I tried to cover this slide in my previous presentation. Just remember that in cohort studies, we will look forward to see the effect of exposure on our health. And here, from cause to effect, I would say that. So this is the cause of the disease, and here is the effect. And key element of cohort studies is time. Why is time? Because as I already mentioned, you will follow your participants, study participants, over maybe a long period of time, and you will wait to see the effect of exposure on the outcome. And basically, cohort studies are really, really great for examining the association between exposure and outcome. And in these games, you are sure that exposure was happened first and then the disease was occurred. Anyone knows what is this about? I mentioned in the previous presentation that the causality cannot be determined in case control studies or cross-sectional studies, but here we really can. Why? Because first we had access to the exposure, and then we are going to see the impact of this exposure on any outcome, which we call it temporal relationship. Okay, temporal relationship. So I'm gonna skip this slide because already we are out of time. Here there is one key point for you. Cohort studies must be free of the disease under a study. So if you are going to see the effect of smoking on the risk of cardiovascular diseases in your city, so for sure you have to exclude those individuals who already have any type of cardiovascular disease. So it means cohort studies should be start with a healthy population or a population that they don't have the disease that we are going to examine. So I would like here to highlight something for you. Multi-site cohort studies are nowadays becoming really famous in the world. For example, in my previous project, I used 13 cohort studies just to examine the association between meat consumption and risk of bladder cancer. So as you see here, cohort studies all around the world are becoming really familiar, and if you can extend your network and can have access to different cohort studies all around the world, you can really benefit from this. And fortunately, I'm doing so, and I highly recommend you to just contact the PI of other previous cohorts all around the world and try to have access to their data, analyze them, and write a publication. If I ask you which study design is the best one in order to understand the natural history of the disease, definitely your answer is cohort studies. Why? Because our study is started with, free of the interested disease. So in this case, we have access to the exposure or several exposures maybe, and then you can see if the disease is occurring. So it's the best time to see the natural history of the disease. There are lots of cohort studies. For example, lung cancer and smoking. You will follow a smoker non-smokers, and we'll see if they are getting lung cancer or not. If yes, our recommendation is to avoid cigarette smoking, for example. Unprotected sex and HIV. So, for example, we are going to follow some individuals, maybe high risk individuals. And then we will see if they are getting HIV or any other, related disease. Then we can suggest that people to avoid unprotected sex and so on. For example, to prevent heart disease, you can suggest your population, yes, LDL and HDL level are really correlated, let's say associated, not correlated. My apologies. Because correlated is, as I said, we mainly mention it in ecological studies. So, for example, high LDL or low HDL level can cause heart disease, and so on. So, in order to analyze cohort studies, as I mentioned earlier, and also I wrote in our chat here, I mentioned that in cohort studies, we look at incidence rate. So key elements here, we look at incidence rate among exposed people, also among non-exposed individuals. So why we are doing so? Because we are going to calculate relative risk. You remember odds ratio from case control studies? Here we have relative risk in cohort studies. So maybe we cannot, right now, I cannot cover these 2 points, but it's okay. You can simply have access to these 2 calculations also in Gordis epidemiology. Okay. I really like this slide. I really like this one because this shows how a cohort study can be done. You have healthy people, and then among these healthy people, some of them have exposure to, for example, cigarettes or, for example, air pollution, and the others may not have. So we are classifying individuals to exposed and non-exposed. And then over the years, we are looking at the individuals. If these people who already have, exposed to smoking, if they are sick, I mean the yellow one, if they are sick or not. So remember, healthy individuals, those who are exposed, the red one, and the yellow one are sick people. So here we look at sick people among exposed and sick people among non-exposed individuals. Like this, incidence of disease in exposed is those who get sick among all the population who had exposure. Incidence of disease among non-exposed, also the disease among all of them who had no exposure. If you simply divide these 2 elements, simply you have relative risk. It's really easy, no? It's really easy. I try to make it for you as simple as possible. Okay. Let's go to our famous cross-tab table, the previous one that we also mentioned. Here we have disease, and here we have exposure. Yes, no, yes, no. Those who have the disease and also the exposure A, no disease, but yes, exposure B. Yes, disease, but no exposure C. No disease, no exposure D. If you just compare it with the previous slide, this is exactly the same. Exactly the same. So if you are going to see the incidence rate among exposed, simply A divided by A plus B. Do you remember how we calculated in case control studies? The approach was different. because here we are looking at the disease. If the disease was happened, but there we had exposure and we had the disease and we wanted to see if exposure was happened. It was A divided by A plus C. Just remember, okay? Incidence rate among exposed and incidence rate among non-exposed. Incidence rate among non-exposed. These are non-exposed people. Okay, let's go ahead. So simply you can calculate relative risk in your study. Fortunately, you don't have to calculate it by, like a calculator or by Excel file or something like this. You can simply analyze it using SPSS, Stata, or Python. And if I had any chance to join you, for sure, I will empower you guys to analyze your data, no matter which analytical software you are going to use, SPSS, Stata, Python, or I will enable you all to analyze your data properly and to visualize and also to make a clear report out of your data. So this is the way that we calculate RR, or relative risk. Do not, confuse. Don't make yourself confused by by odds ratio. Odds ratio was for case control study. Relative risk is for cohort studies. So suppose at the present, right now, you have some individuals that have high exposure to sun ray, and others, they really are not like to be exposed to sun ray. Over the years, in the future, maybe after 10 years, 15 years, you will see the occurrence of basal cell carcinoma. It's a skin cancer among this group. So these people, 40, they had exposure and they became sick. But 360 people, they don't have any disease. Okay. And if you can simply put these numbers in your formula, you will have your relative risk. Again, if relative risk is above 1, is a risk factor. If it's less than 1, it's a protective factor. It means, for example, your calculation came to number, for example, 2. In this case, you can say exposure to sun ray can increase the risk of basal cell carcinoma 2 times higher than who had no exposure to sun ray. Okay, this is the interpretation of the results. If, for example, you are choosing a protective factor, like for example, how to say that, like beta carotene. If you are trying to give the participant beta carotene and you will reach RR equal, for example, 0.8. In this case, your exposure is protective against, for example, basal cell carcinoma. Why? Because this is less than 1. Okay, here there are some key factors in cohort studies. As I mentioned, temporal relationship. We can easily find the temporal relationship between exposure and outcome, because we are 100% sure that at the start of our study, no one was sick. No one was, no one had any outcome like cardiovascular disease or cancer and so on. And basically, this really needs a valid diagnostic tool. So if you're going to perform a cohort study, for sure you have to screen your individuals in order to make sure that no one is sick. If yes, then you have to exclude it from your study. Or related diseases. For example, if you are going to if you're going to look at your population to see the outcome of cardiovascular disease, any disease that is related to cardiovascular disease should also be excluded. I would also suggest to maybe exclude diabetic patients, maybe. Yeah, because diabetes and cardiovascular diseases really have direct, correlation. Okay. Causality assessment, as I mentioned, multiple outcomes. For example, you are going to see the association between exposure to smoking and the risk of cardiovascular diseases, also the risk of, for example, cancer, and so on. Here, as you see, multiple outcomes were examined. As I said, a relative risk measure, we can calculate relative risk, and this will enable us to have the incidence of the disease. So it's obvious that we look at exposure measurement. In longitudinal studies, will help us to see the natural history of the disease. This is suitable for rare exposure or risk factors because we are trying to see the effect of this rare exposure on the risk of a disease. But please remember, if your disease is rare, the best study is case control study, not cohort study. And why? This is obvious. We cannot waste our life for 10, 20, 100 years just to see one rare case in a population. So this is logical. So if the disease is rare, your best approach for sure is not cohort study. So prognosis and disease causation, I already mentioned this one. Ethical consideration, same as case control study, I would say that ethical consideration is not that high because the exposure is out of your control. So this is obvious when you are not implementing any exposure to the society or to the population. So the ethical consideration could be low. This one is a bit advanced thing. It means cumulative exposure effect. This means if a person, for example, had exposure to, for example, sun ray, for example, smoking, for example, low diet, and so on, multiple factors, then we can see the effect of all these factors together on the occurrence of the disease. So I'm not trying to, highlight this one. Let's go to the next slide. Okay. Right now, I said a lot of positive things about cohort studies, but this is not the case. This kind of studies may be really, really expensive to do because, as you see, you have to put lots of energy, you have to put lots of efforts just to see the occurrence of the disease in your population. Long follow-up. This is time-consuming. Selection bias. It's a really big issue also in cohort studies because if you select the population that are really not representative of the general population, it can be problematic. For rare outcome, as I already mentioned in the previous slide, this is not the best approach. Sometimes ethical concern may exist, but it's not that big actually. Of course, this is not the best approach for all the research questions, so this is obvious. And let's say confounder factors. Okay, confounder factors is another factor that can affect cohort study results. Why? For example, suppose I am having a cup of coffee, and then after 10 years, you will examine, yes, Mostafa had for example, 5 cups of coffees each day, and after 10 years, you are going to see if there is any outcome in my body or not. Then somebody will say, okay, you are, for example, at a higher risk of X disease. Okay. And then maybe somebody says, this is because of your coffee. But this is not the case. Maybe I had another exposure. Maybe the fiber, or maybe, for example, my poor diet was the main reason. So it means when you are performing cohort study, make sure to cover all the necessary exposure in your, for example, medical records, in your questionnaires, or in the assessment tool that you are trying to use. Okay, here a comparison between case control study and cohort. Case control effect to cause, cohort cause to effect. Let's start with disease in case control. Let me use my pointer here. Let's start with disease, let's start with exposure. In case control study, we test whether suspected cause is more frequent among disease or undisease. However, in cohort study, this is completely on the other side. We start with fewer subjects, but in cohort studies, mainly our sample size is really high. In cohort studies, we have quick results, but in cohort studies, most of the case we need long follow-up. As I said, suitable for rare disease, rare exposure. In case control study, you see OR or odds ratio in publications. However, in cohort study, mainly you see RR or HR, hazard ratio. And yeah, it's obvious that case control study are cheap, but cohort study are really, really expensive. Here, I just mentioned some pros and cons for case control study that I already covered in my previous lecture. Just if you would like to just have a look, please feel free. Okay. There are some famous cohort studies all around the world, and I just put them here for you. Then I will share all the presentation with you all, with Professor Long. I will share all the presentation with you after some adjustment, actually. And then try just to Google these cohort studies and read about them. For example, Framingham cohort study is really famous one, Nerd Health study, Women Health also cohort study, or maybe Persian cohort study. These are really famous cohort studies all around the world. Perfect. If you would like to participate in this lecture with me, yeah, I make this part blind, okay? You will have access to this one later. I would like to ask you questions. For rare exposure, which study design you will use? For rare exposure. Anyone? Hope to hear from someone. And how about for rare disease? For prevalence estimation? For temporal relationship? Which one is more efficient in data collection? Which one use longitudinal data? Which one you will use for identification of risk factors? Which one has less bias? Okay, I hope though you can say which one you are speaking about. I think you are speaking about the rare exposure. If yes, great job. Okay, let's show you. I suppose maybe I can have, perfect, great. I thought maybe more participation I can have from you guys, but unfortunately, no. this is blind for you guys. I'm gonna make it yes. Yeah. Perfect. And then no color. Here also no color. I'm trying to show it to you guys. So just a second, please. Okay. Now the answers are here. The answers are here. Yeah, bravo. Good job. Case control study for rare disease. Yeah, perfect. So because we are out of time, yeah, thank you all. Thank you all. I appreciate your participation. Just in order to save our time, here you can see the answers for each feature or characteristics. Okay, and here are the main references that I used for this presentation. And basically, this is the last slide for cohort studies. I already have experimental studies and just a glance at systematic review and meta-analysis. So if you agree, maybe we can come back after 5 minutes. Feel free to grab a cup of coffee or something, and then we can meet after maybe 5 minutes. Do you agree? Yes, I will try to share all these slides with you for sure. This is your right to have access to these slides. Okay, so I will see you after maybe 5 minutes, okay? Let's see. My camera is off and then I will see you. Perfect. So let's get started. Just one single point about cohort study I have for you. Okay, exactly. Yeah, by the way, can you hear me? Can you hear me clearly? Perfect. Thank you so much. Okay, do you remember this slide? This one was about case control studies, okay? Exactly the same as case control study, we use a strobe for cohort study and cross-sectional study. So keep it in mind when you are preparing your reports and you are going to write a paper, I mean a manuscript. Yeah, keep it in mind to also write the report according to a strobe. And also, as I mentioned in the previous lecture, if you can submit also the checklist, that would be really great. And the editor will be really pleased. Okay, perfect. Let's go ahead. Let's start with experimental studies. And actually, guys, I think this is one of the most best studies for you in order to do your thesis, maybe. Of course, cohort studies and case control studies are also, both of them are good approaches. But here, let's start and speak about experimental studies. Okay, suppose you are trying to invent a new vaccine, or you are trying to see the effect of a new drug on the patients or on the healthy individuals, or you are trying to use a vaccine in order to prevent a disease. So which study design you will select? This is obvious. Why? Because you are manipulating the exposure. Okay? Let's speak about trial and clinical trial. This is one of the best and top studies in the world. Trial came from the French trial, which means try. So we have clinical trial, which means apply therapeutic interventions to sick individuals. For example, you are going to see the effect of chemotherapy trial on the patients. We also have field trial, apply preventive intervention to healthy individuals. Mainly in this category, we have vaccine trial. Also, sometimes we have community trial. The last category are really not that famous and that often, but still we have community trial. For example, apply interventions to aggregate unit like fluoridization of public water or something like this. Okay, experimental study design. Let's speak about it. Do you remember this slide? So, do you think we can categorize experimental studies here? For sure not, because this is not an observational studies. But let me go to the next. This is an experimental study, which means you are controlling and you have control over the exposure, which can be randomized, okay, or non-randomized. So for field trials and community trials, they are non-randomized in nature. So sorry about this one. I will correct this one later for you. So, do you remember during the previous lecture I mentioned, please try to keep this slide in mind? Yes, because right now we need it. Here, this asked us, does investigator decide for exposure? And the answer is yes, because you're using a vaccine or a drug or an intervention. So then your study is experimental study. Are you going to randomly assign participant to drug and placebo? If yes, this is RCT. If not, this is non-randomized controlled trial, okay? And actually here, I can say that same as cohort studies, in trial studies, we also have exposure and then we look at the outcome, okay? Just this is a common thing between cohort studies and interventional studies. First, we have exposure, and then we are going to see the outcomes of the exposure. Okay, perfect. Let's go ahead. Study design. Exposure not manipulated by investigator. So we know that. It can be cohort study, case control study, case risk, cross-sectional, or ecological studies. Exposure manipulated by you? Yes, this is experimental study. So it means it's a clinical trial. For experimental study, first at baseline, here you have a study population. Then you will randomly allocate people or the participants to intervention or control. Let me say something magical for you here. If you are reading like a study which is experimental study or RCT, randomized control trial, please keep it in mind, RCT. I'm not going to say randomized control trial several times. So if you are randomly assigning this population to intervention and control, we call it randomized, okay? If the investigator, okay, and also the participants are not aware of the drug that they are receiving, their study is blind. So we call it double blind, which means both you as an investigator and also your participant, they are not aware of the drug, if they are really receiving the placebo or they are receiving the main drug, okay? The main intervention, I mean, the main pill, the main vaccine. So this is double blind. If none of the participants, also you, also the analyzer, the person who is going to analyze your data, none of you are aware of the assignment of the participant to each group, really you have no idea which one is in intervention or which one is the main drug, main intervention, which one is placebo. Then this will be triple blind study. These are amazing studies, okay? Triple blind. Okay, let's go back. Study population, we have randomization here, intervention or control. Then we will see, for example, the incidence of the disease during intervention group, and those who are not became disease in intervention, also outcome in control and non-outcome or no outcome in control group. We will see these things in the future. Do you remember in the previous slide, I mentioned somehow the design is similar to cohort study. If you have any question, please feel free to raise your hand and ask me. Of course, it's fine. So this slide will help you to decide which study design is appropriate for your idea. For RCT, investigator allocate the exposure. If you have no control over the exposure, then think about observational studies. So why we apply RCT, randomized control trial? Yeah, basically in medical science, in epidemiology, this is the gold standard in research. This is the gold standard in finding the association between any exposure and outcome. This makes study groups comparable controls for confounding also, because when you are randomly assigning people to different groups, by nature we are controlling confounding because we are not aware if the participants' behaviors are the same or not. They are randomly assigned to different groups, and we suppose that all the confounders are equally distributed in both arms of the study. Okay? And when you are doing randomized, this can prevent selection bias. Yeah, why? Suppose you have like 100 patients, and the status of their disease is not that severe. So you are trying to see if, for example, this new drug has benefit on the, for example, let's say recurrence of the disease or not. Because all the patients are randomly allocated to arms, you are not manipulating the population. Yes, you should go for this one. You must go for this group. Then selection bias is not exist by nature. I hope it's clear for you. If not, please let me know. So interventional studies can be categorized as therapeutic or preventive studies. For example, a study population here is patient with a disease. And then we can have different objectives for this kind of studies, okay? Like diminish symptoms, cure patients, prevent, for example, recurrence, and so on. However, for preventive, like vaccination, for example, a study population is the whole population at risk, and we are going to reduce the risk of developing disease. I would say the risk of incident cases of the disease. Let me say something in between. Guys, please remember, for prevalence, all the new cases and old cases means prevalence. For incidence, only new cases are considered, okay? So keep it in mind from now on. Prevalence means old cases and new cases that happened recently, but incidence, only new cases that happened recently, okay? For design of this kind of studies, we have different phases like enrollment. For enrollment, for sure, you have to have clear definition of the outcome, clear definition of which participant can participate in your study. Then you can allocate the study, for example, intervention. Then, same as cohort studies, you must have a follow-up to see the effect of your intervention on the incidence of the outcome. And finally, we have analysis and interpretation of the results. Okay, here also we can select a study population like from reference or source population, like from the whole population of your city, your country, maybe. In this case, the generalizability of your data is really high because you randomly selected people from all around the city or all around your country. So experimental population, we have to always keep it in mind, the actual group that are going to be included in our study. You have to have clear sample size calculation. For sample size calculation, for sure, I cannot cover it in this course, but maybe for sample size calculation, maybe we can have another presentation for you in order to calculate sample size for each study, okay? Also for RCTs, please bear in mind that you need to have a clear definition of your endpoints. For for example, recurrence of the disease, or like cure or relief of the symptoms, and so on. Let's go ahead. My apologies. In order to start your study, all the participants should be aware of risks, benefits, and also the nature of your study. Okay? And also, the main intervention or placebo should be blindly assigned to the participants. So no preference. For example, if one of the patients is your relatives or your friends and so on, you shouldn't allocate it to, for example, to the main intervention. Should be everything blind. Guys, for RCTs, ethical consideration is really high. Really high. So all the participants must have to be sign the informed consent. There is a form, the patients or the individuals, they will read it carefully and will sign it, okay? By this, they will show that they are willing to participate. So please also try to have clear definition of inclusion criteria and exclusion criteria. This is really vital. So, as I already said, selection of a study population can be from the whole population or can be from a small size of population. For example, if you are going to start your study with the whole population of your city, or if you are going just to apply this study only to, for example, nurses, or only to children's, or special groups. So, allocation of a study regime. After the patient showed their willingness to participate in your study, you will randomly allocate a participant to two different groups. Then you will decide, actually not you, then you will randomly allocate the drug or the intervention to both groups, okay? Yeah, I already covered this slide for you, so let's go ahead. So type of trials. Trial is controlled, so it's randomized. Can be blind or not blind. If it's blind, so not only the investigator but also the patients and the analyzer, they don't have any access to the data that which patient was assigned to which study arm. So an RCT or experimental study in which subjects in a population are randomly allocated into groups, usually called a study, okay, into groups or study groups. So we mainly classify these two groups to study groups and control groups. And the study groups will receive the main intervention, and control group will receive like a placebo or like something that is similar to our main intervention. So, as I said, we can have randomized control trial or non-randomized control trial. Here I have a question for you. When we have to use non-randomized control trial? Basically, sometimes, yeah, it happens. In real world data, it happens. And we have to go for non-randomized control trial. Yeah, suppose you have like 100 colorectal cancer patients. Out of them, you are going to assign 50 patients to, for example, a drug, and 50 patients to surgery. So you are going to randomly assign each patient to one of these two arms. Then, while you are going to assign the participant, you see that, okay, some patients are really have no good condition, and they must have to be, assigned to surgery because they really need surgery at the moment right now. Then this is not randomized. Then you are going to just allocate the patients who are having severe disease to surgery, and those who are not having, bad condition, you are going to assign it to your, for example, any new drug that you have. So non-randomized controlled trials, as you see, by nature, they have biased, mainly selection bias. Randomized controlled trials, yeah, completely same as cohort studies. But the key element here is random assignment and allocation of the exposure. So two main difference here, you see, random allocation. We also decide about the exposure. So I try to cover this one already covered, as I said, reference population or specific population, and then randomization we will apply. For sure, we have manipulation in our, for example, intervention. And then we have a key factor here about follow-up. Same as cohort studies here, we also have follow-up in order to make sure that the effect of this exposure already happened, and we can see the main effects of this intervention on the disease. And for sure, we will have the assessment, and we see if our intervention has a positive results, if it's beneficial, or negative results, and if it has some maybe side effects. So basically, if RCT is not possible, as I mentioned in the previous example, like if you have like 100 patients with colorectal cancer and some of them are in a really bad condition and you are going to assign them to surgery. So here it's not ethical to you as a researcher just to assign a patient who is not in a really good condition, just assign it to the, a new drug that you are going to test. This is really not ethical. And this patient needs urgent attention. So basically, when disease frequency is low and natural history is long, we also can use non-randomized trial. And the reason behind that is that basically we have no idea. We have no idea about this disease, if it can happen or not in the future. So basically, we are going to just try our new drug and see the effect of new drug on the society. And also, randomized trials are really expensive. However, non-randomized trials cannot be that expensive as randomized control trials are. So let's escape this slide. Let's go forward. Then you will have to access to my presentation, because we also have systematic review and meta-analysis. I wanted to cover that one also. So experimental study examples. There are several examples that I can show you. For example, randomized clinical trial to determine if giving any supplement, to pregnant women in order to see any outcome in their, for example, newborns. So it can be use of, for example, high fiber diet. It can be a diet in, for example, monounsaturated fatty acid. on the risk of maybe brain development and so on. So you are going to apply an intervention on your society, on your patients. Basically, they cannot be patients on the participant, let's say. Or maybe randomized control trial to determine if fluoridation is associated with decreases dental cavities. This is also an example of experimental study. So here I need your 100% attention. Randomized control trial can be parallel design or crossover design. Parallel design and crossover design. Okay, field trial and community trials, let's skip it from now. My main concentration now is parallel design and crossover design. Let's go ahead. So I already covered this one for you, fortunately, during my presentation. And also, let's see. They have reference population here. And then randomly, you will find experimental population. Then some person or some people maybe cannot be included in your study. Then we will exclude them. Here you have to write the number of patients or the number of healthy individuals that couldn't participate in your study. Finally, you have a study population. You can randomly allocate intervention or control. Of course, after implementation of intervention or after having control group, we have loss to follow up again. This is normal, no worries at all. And then you will see the outcome in intervention arm and control arm. Okay, parallel design and crossover design. This is really important and interesting, and basically you can do it maybe as soon as you have enough time or resources. Here, random assignment. We have random assignment and then exposure to a specific, for example, beta-carotene or not. And then we will see their effect. Let's go back. This is parallel design. And for crossover design, you have patients. Then they will start with, for example, a specific intervention like higher intake of, let's say, let's change my example to vaccination. They have exposure to this vaccine. They are not having exposed. They are not having exposed to this kind of vaccine. Okay, after a short period of time, then we will change both arms. This group will receive nothing or maybe placebo, but this group will receive vaccination. Then we will compare the results between two groups. A key factor here is a washout period. It means you have to specify maybe like 1 month, 2 weeks, depend on your exposure, your intervention. You have to specify a washout period in order to make sure that the effect of this exposure or intervention is cleaned, okay, is disappeared. And then you will change your arms, okay? And we call it crossover design. Basically, crossover design is mainly used for new drugs. For example, you are going to use a new drug in order to see if this drug has a beneficial effect on like brain development or not. And here you have a placebo. Then both groups will change, their, intervention, receiving or not receiving, and then we will see the outcomes. Okay, here are some advantages of experimental studies. For sure, exposure is under your control. Then randomization, which can really reduce bias, mainly selection bias. Then you have control over the participants, and then confounding factors can be controlled. As I said, because randomly patients or individuals are assigned, so we assume that main confounders are equally distributed. Best method to study causal relationship is for sure RCTs, and after that cohort studies. So as I said, it's golden approach. And when you are going to confirm or refuse etiological hypothesis on evidence, for example, you found that higher intake of beta carotene is associated with lower risk of heart disease. Yeah, we found this one in a case control study, in a cohort study, and then we can try this one in an experimental study. If we also reach the same result, then we can say that yes, this one has a really beneficial effect on the risk of cardiovascular diseases. Of course, there are some disadvantages for this kind of studies. Subject exclusion or attrition may really affect the generalizability of your findings. Sometimes really need long time to see the effect of your exposure or your intervention on the society or on both arms. Sometimes for some drugs or maybe vaccination, a large number of participants needed, and this means really huge sources. And also ethical concern may arise. Yes, this is really a key point in clinical trial studies, that ethical considerations is the main issue. Also, subjects or participants may not completely comply with the treatment assigned. This happened in a study that I personally had. Yeah, this really can happen. Sometimes, participants are not really, following our protocols, and they are not, taking their pills, or they are refusing to do, for example, if your intervention is physical activity, you ask the participant to do physical activity 20 minutes per day. The other group, maybe you will ask them to eat, for example, a healthy food. So maybe participants, maybe refuse. In this case, the best approach is to define your intervention really clearly. And if your intervention is under control of the patients or participants, this can highly impact your results. Yeah, I try to cover this one also. Let's move forward. Okay, same as observational study, we have all these elements, but randomization is a key factor in randomized controlled trial or experimental studies. So the main difference with other studies is randomization and your control over exposure. Okay, let's move forward. We can have two groups, exposed and non-exposed. And here in this kind of research, we have a really famous term, and we call it MRFIT, multiple risk factor intervention trial. For example, your exposure is health education versus no special intervention. So in your society, you are going to use health education, and for some other cities, maybe no special intervention, and your outcome is cardiovascular diseases. You are going to see the effect of your, for example, health advertisement through television and so on, and to see the results on your society. At the same time, we are having, for example, some programs for lowering hypertension, like, for example, this lipidemia, glucose, and so on, and so on. Okay. In this case, we have multiple risk factor intervention trial. And maybe if you're just looking at one single intervention that is health education, maybe you cannot see the real effect of your intervention on the society. In this case, it's better to see the whole packages of the interventions at the same time. Also, in clinical studies, we have placebo effect. Sometimes we have improvement associated with inert interventions. Let me say something really obvious to you. In a study, there was two kind of pills. One of them was placebo, and one of them was the main drug. And the researcher randomly assigned these two pills to two arms of a study. And after that, they were supposed to see if the headache of patients has relieved or not. It's really interesting that both group has mentioned that their headache is relieved, both in placebo group and in the main intervention group. So in this scenario, we have placebo effect. And so basically, when your outcome assessment is not obvious, so you have no control. For example, you have no golden standard method in order to see if the patients really have headache or not. This can seriously happen. So we also have placebo effect. Even though they received a placebo drug pill, but they have reported improvement in their health condition. Yes. Hawthorne effect, we also have something here, and this is really interesting in interventional studies. It says subject improve an aspect of their behavior just because of being at this kind of study, because they are going to follow some particular experimental manipulations, and then both groups, both the interventional group and placebo group, they are following some protocols, and it's highly likely that they can change one aspect of their life. Suppose your intervention is to see the effect of like a new drug on the risk of cardiovascular diseases, and one group is receiving the main drug and the other group is receiving the placebo. But because both groups, they know that they are under a study, maybe they will change their diets. They will change their physical activity. So this change also can impact our results. So you should take this one into consideration. Yeah, remember that in this kind of studies, really randomization is a key factor in order to make both groups comparable and also to avoid confounding factors. So I would like to say that how randomization works. Suppose you want to determine whether a particular diet, for example, a high fiber diet, is associated with, for example, improved weight gain in lab animal or not. If you have, for example, 10, for example, animal that are not in high weight, or maybe 10 with high weight, you cannot just simply align them or make them specified. Yes, those with high weight can go to this group and low weight to this group. In this case, your ascertainment of the individuals or the subjects is biased. So you have to go to randomization. You have to randomly assign so that you see equal distribution in both arms. So let's go ahead. Yeah, we have some example from field trials in the history, which was about polio and polio vaccine. Okay, please remember that in your study, you have to have really clear definition of your outcome. Because if you don't have a clear definition of your outcome, then for examining the association between the intervention and your outcome, maybe you are not that specific. Do I have any question? No. Okay, let's go ahead. Yes. Ethic and ethical consideration in these studies is really a big issue. First of all, respect for all individuals in your study. They should be aware of the beneficence, risk, and any outcome that you think can have on the patients or on the individuals. Justice, and also they should be completely aware and should write informed consent form. Let's go ahead. Yeah, please remember that for clinical trials, we have several phases. First, we have preclinical, phase 1 trial. Preclinical mainly, for example, in order to see the effect of a vaccine. First, we will use in the lab or animal or something like this. Then you have phase 1 trial, phase 1 trial, which includes some limited patients, main or healthy individuals, depend on your intervention. And basically, a small number of individuals can be included in phase 1. Normally, we can 50 or 20 to 80 participants. Then we have phase 2 trial. And in this case, we can say that up to 500 individuals can be included. And then we will look at, for example, the safety or, for example, adverse effect of the intervention. Phase 3 trial that can be 1,000 or 100 individuals in your study. And in this category, we mainly look at the safety and efficacy of our trial. Maybe you can think about COVID-19 vaccination. The majority of people when receive the vaccine, then I personally did a study to see the safety and efficacy of different kind of vaccine on the society. And then we will go forward in order to approve this intervention or this vaccine. And then in order to have it confirmed by FDA. Okay, let's wrap up with some key points. In your publications, there are some key factors that you must have to follow. Like, for example, checklist and flowchart that is assigned for this kind of a study. Okay, as I said, for observational study, we had like valid and like general form in order to report our findings. Here for clinical trials, we must have to follow CONCERT. Okay, CONCERT 2020-10, if I'm not mistaken, a new version also is released. Not 100% sure. Maybe you can also check. So you have to go for this checklist, this statement, and also in the first line of your method section, right after you mentioned that participants were included ethically into your study, you must write that the results and the methodology of this study is prepared according to the CONCERT. Remember that for observational studies, we had a strobe. Keep it in mind for our next presentation for systematic reviews is PRISMA. PRISMA, strobe, and CONCERT. These are key factors that I want you to prepare in order to write your manuscripts in the future. Concept has some elements about title, introduction, method, also about your results and discussion and other information that you need. This is a really key factor in preparation of your manuscript. Try to use it, try to read it, try to see what editor and reviewers are trying to point out. Also, in the method section of your study, you must have to provide this file for the reviewers and editors to say that how many participants you wanted to include and how many of them were excluded. Then randomization was applied for how many people, and then allocation, how many individuals in control group and how many individuals in the drug or intervention group. Then follow-up, how many patients or how many individuals you have lost to follow-up, and then analysis of your data. It means how many individuals you could do analysis on them. Okay, try to keep in mind that we have a really vital thing about experimental studies, mainly RCTs, that is good clinical practice, GCP. GCP is an international ethical and scientific quality standard for all the studies in these categories, for all aspects like designing, conducting, recording, reporting, and every phases of the study that involves human subjects. Why we use GCP? Because it ensures that the rights, safety, and well-being of trial participants are protected. So this is really vital in order to approve a new drug or new intervention. It has some key elements, as you see here, like ethical conduct, the design of your study to see if it's sound, clear, and also about documentation, records, and other aspects of your study, like safety reporting, trial monitoring, quality assurance, data integrity, and so on. Also, please feel free to search about GCP, which is really important. And if even you are going to find a job in industry, which is about performing clinical trial studies, you must have to know about GCP. Okay, just to have a summary, this is a gold standard in epidemiological research. We can make a study groups comparable random allocation, and then we must have sufficient sample size. We have sample size calculation for this kind of studies, and also unique problems of ethics, feasibility, and cost. Yeah, basically ethic is the main feature of this kind of studies. Sometimes it's not feasible to do this kind of studies, and the costs are high. So when you are going to perform an interventional study, try to keep in mind and try to see if it's ethical, if your cost is enough, if it's feasible for you, and then go ahead and run your study. Also for these slides, I tried to use the main textbooks that are available in epidemiology and medical sciences that are related to study design. And yes, let's go ahead and start with the last part of my presentation, which is about basically review studies and meta-analysis. By the way, if you have any question, feel free to ask me. Otherwise, we can go ahead and continue. Any question? I think no question because I can see. Okay, perfect. By the way, sorry, guys, I'm really sorry because as I mentioned for several times, for each study design, I really need at least 2 hours. I tried to just capture some main features of each study for you. I really put lots of hours in preparation of the key points for you. Sorry for missing any information if you maybe wanted to know more about it. But believe me, I tried to highlight and to point out the main feature of each study for you. At least you have an overview over the wide range of different studies. Hopefully in future I can teach you more and more. Amazing. If you have any question in between, feel free to interrupt me. It's my pleasure. It's my pleasure, Adam. Thank you. Thank you. Yes. Perfect. Also, feel free to call me, contact me via email, or maybe through social medias. It's completely fine. Hopefully, in the future, we can run some study designs, work together. I'm looking forward to it. Okay, amazing. Let's go ahead and for literature review. In this part, I would like to cover narrative review, systematic review, and meta-analysis, just to cover some basics and overall perspective of these kind of studies. And fortunately and hopefully in the future, we can do systematic review and meta-analysis practically, because really no need to huge budget, no ethical consideration. And if you can just do systematic review and meta-analysis, the majority of journals are really appreciate these kind of studies. And yes, you can start with these kind of studies. It's really interesting. However, they have their unique design, and hopefully I can help you to do some systematic review and meta-analysis. Perfect. Let's go ahead. Okay, guys, I have a question for you here. Read it with me, please. Suppose there are 20 publications available that suggest red meat might increase the risk of bladder cancer. So here we have 20 publications. These 20 publications, they are saying red meat is increasing bladder cancer. However, 8 publications showed no significant differences. Oh, okay, interesting. 8 publications, they are saying there is no association. There is no association between red meat and bladder cancer. And surprisingly and shockingly, 2 articles suggest that red meat may prevent bladder cancer. Yeah, we see here lots of discrepancy between the results. Each study is saying its own word. Is it really true? How we can make a conclusion over these like 30 studies that the majority of them are saying yes, increased risk. 8 out of these 30 publications, they are saying no association, and 2, they are saying red meat may prevent bladder cancer. So which study design would you use to examine the association between red meat consumption and bladder cancer risk? Yes, it's obvious. We will use systematic review and meta-analysis. As you see, they are really generating high quality of evidence for us. There are several types of review studies. We have reviews, which can be narrative, literature, traditional reviews, or can be systematic review or meta-analysis review. So generally reviews, narrative reviews, systematic reviews, these are really specific, and meta-analysis studies that I will show you. Okay, literature review defined as systematic, explicit, and reproductive way to identifying, evaluating, and interpreting all of the resource or research finding available on a certain or a specific topic. Yeah, remember my first slide and my first question. So a high quality review is not really by chance. it means they have to follow some criteria in order to produce really high, effective, and standard evidence out of our publications. Ideally, we say all of the existing previous publications should be included in your literature review, but hopefully it's applicable, it's possible. Okay, so we can perform literature and systematic review over the both observational studies and experimental studies. So it doesn't matter if you are going to see, for example, the effect of, for example, red meat on the risk of cancer. Mainly, the majority of the studies are observational studies, because you are not going to, as an intervention, give some people red meat and give other people, like fish and fish products. This is out of your control. Or if you are going to see the effect of a specific drug, for example, you are going to see the effect of iron during pregnancy, and to see the effect of, for example, this supplement on brain development among newborns, you can pull all the available evidences, all the available experimental studies, and perform a literature review. We have systematic review and narrative reviews. Systematic reviews, scientific approach to review articles. So we have a specific approach for that. But narrative reviews, it's like telling a story. So this is biased, because author or the investigator can, continue this review from any perspective that he or she would like. Okay. For systematic review, really we have some criteria, but for narrative reviews, I would say really there is no specific criteria. For systematic review, we have comprehensive search and search strategy, and we are trying to find every single study. But narrative review, basically the researcher can just search for any database that he or she likes. For example, just go for Scopus or PubMed, or maybe just can go for Google Scholar, something like this. For systematic review, we have methodology, but for narrative review, we really don't have methodology. Okay, for systematic review, we can perform meta-analysis, but here we can really not perform any analysis on the data, or we cannot drive any robust conclusion out of these narrative reviews. Okay. There are some differences between narrative reviews and systematic reviews, and please feel free to read these items and reach out to me if you have any question about them. I'm gonna go ahead. Yes. Perfect. Yeah, please remember, narrative reviews usually written by experts in the field. So try, if it's your first scientific work, please try not to write a narrative review as, the start point of your, academic life. Because narrative reviews, sometimes, for example, I myself as an editor, I will ask, a person who is expert in a specific field. I will ask he or she to write a narrative review about this topic, because according to his experience, his previous research projects, and his knowledge, he can tell me a really narrative, like a story. So mainly narratives can be conducted by experts in the field. And narrative studies mainly, summarizing the evidence, and they are not going to see the logic or to see if this association is real or not. However, systematic reviews, Systematic review clearly formulate questions that use systematic and explicit methods to identify, select, and critically appraise relevant primary research, and to extract and analyze data from the studies that are included in the review. So here we have a specific criteria in order to include studies in our study. But in narrative reviews, actually, we didn't have such criteria. So systematic review is comprehensive and unbiased summary. As you see, narrative reviews, they are biased summary because, as I said, those expert, researcher can go to any way that he or she likes. Okay. So we have a really robust method to identify, select, appraise, and synthesize all the relevant studies. And why systematic reviews are important? Because systematic reviews are useful in order to show reliable and up-to-date summary of all the available evidences all around the world about a particular topic. And this, overall view can help clinicians, policymakers, researchers, stakeholders, and anyone who is going to change our health or who is going to apply any changes. At least he or she, this, policymaker or stakeholder, has something robust in order to make or apply a change. And what is meta-analysis? A meta-analysis is a statistical method that combines the results of multiple results to produce a more precise and reliable estimate of an effect. Remember, in meta-analysis, we are speaking about numbers. Do you remember in case control study, we had odds ratios, and in cohort studies, we had relative risks. Here in meta-analysis, we are going to pull all the numbers together, okay, and analyze all these numbers together and to make a conclusion, for example, if red meat is really associated with bladder cancer or not. Okay, meta-analysis is often used in systematic reviews. After doing systematic reviews, it's highly suggested to perform a meta-analysis in order to summarize the evidence on the specific outcome. And how to conduct a systematic review? There are some main elements that you can conduct systematic review. First of all, you need to formulate a review question. You have to be really sure about the question that you are going to answer. If you have enough evidence and the evidence are controversial, some studies are trying to say positive association, some studies are going to say negative association, some of them are going, neutral association, not positive, not negative, no association. So you have to have a really robust and formulate review question. Secondly, you must know which kind of study you are going to select. If you are going to work on, for example, observational studies or clinical studies, then you will go to select the studies. How you can select the studies? Simply by having a clear search strategy. Search strategy must be like, have the outcome, the exposure, the population, and the timing, if time is the matter, okay? If time is important. And by creating and having a specific research query, you can reach the best and all the studies available in the field. And select the studies, assess the quality of the studies. Guys, remember, you cannot include any study, that is available. So in this case, we have a form, we call it Newcastle-Ottawa, for example. And Newcastle-Ottawa form will enable us to rank the studies. If this study is sample size is high, if the methodology is robust, is, for example, the analysis is correct, and so on. If the confounding factors are controlled, if the study is high ranking quality, then we will include it in the meta-analysis or systematic review. If not, yeah, we will exclude it, okay? And synthesis of the data and interpretation of the results. These are the main key elements in conducting a systematic review. So planning the review, identification, the need for a review, preparation for a proposal or review. This is a stage one, which we are planning. And then development of a review protocol. For example, which population, what is your exposure, what is your outcome during, for example, which years you are going to study, for example, between 2010 until 2024. Stage two, you are going to conduct a review, like identification of research, selection of a study, quality assessment, as I said, like performing Newcastle, Ottawa, then data extraction and data analysis. Stage three is reporting and dissemination of your results. The report and recommendation that I have for you in order to report your results, the results of systematic review, really clearly and interestingly. Also, there are some challenges for conducting systematic reviews. Identifying all the available studies, really it's not, possible for us in order to have access to all the available studies. Basically, assessing the quality of the studies according to, for example, Newcastle, Ottawa form or checklist. Yeah, it's difficult sometimes. And the person who is going to assess the quality for you should have some basic knowledge in epidemiology and study design. And I'm happy that you already have some basic knowledge. Sometimes we have heterogeneity between the studies. Let me open this one for you. Suppose you are going to see the effect of, for example, higher intake of monounsaturated fatty acid on the risk of cardiovascular diseases. And some studies are, the study group for some studies are the old population, like about 50 years old age. And for some of them, the population is like between 20 to 30. And for some population, they are like sick people. For the others, they are just working on like diabetic patients. As you see, our population is heterogeneous. We see this intervention has been conducted on different, people, different person with different backgrounds. Some of them are very like old people, some of them really young, some of them are really sick. So this is the heterogeneity between the studies, and we have to deal with this one. And sometimes interpretation of the results might be challenging, and you must have the knowledge of how to interpret the results basically in meta-analysis. I will show you some points later. As I said, there are some benefits for conducting systematic review that I already covered this one. Feel free to read this slide also. There are some examples. The first example that I gave to you was that one about red meat and bladder cancer risk. And here, there are some other examples. For example, here, what are the long-term effects of exposure to COVID-19 vaccine? Some studies, have reported, lower risk of, side effects. Other studies maybe reported cardiovascular diseases. Some studies have reported hair loss. So you're going to see how many studies, for example, mention hair loss is a side effect for COVID-19 vaccination. These are just examples. For example, you will find 5 studies that mentioned COVID-19 may cause hair loss. Maybe 10 studies they mentioned, no, there is no association between vaccination and hair loss. And maybe some of them also say, yeah, there is negative association. COVID-19 vaccination can improve, I don't know, maybe can improve, the growth of your hair or something like this. This is just overall view of, thinking of a study, thinking of conducting a systematic review and meta-analysis. So if the evidence are not in line, maybe this is the best time to go for meta-analysis or systematic review. Remember, in order to perform a search strategy, you need to search at least 3 databases. This is my really high recommendation for you. Try to search Scopus, PubMed, and Web of Science, these 3 databases, and then search for Google Scholar, okay? Okay, for meta-analysis, as I just mentioned, on the top of systematic review, we will perform analysis to interpret the numbers that are driven from systematic review studies. Yeah, the method is the same as systematic review, but we have, in this part, we have analysis. Let me show you this figure. Maybe you have already seen a figure like this. There are different studies. This study mentioned that, for example, vaccination is, this is the effect size. Suppose this is RR, relative risk. This one has suggested that it can increase, for example, hair loss vaccination. But as you see the tails, these are the tails. They are crossed the threshold. So this is not significant anymore. Okay? Because of the tails. This study, however, mentioned it can increase the risk and the tails are not crossing the threshold. This study also saying another number, this one also another number. If we integrate all these numbers together using statistical methods, like what I'm using right now is performing analysis using R programming and Stato. Then we will create one single number out of these numbers that we call it effect size from meta-analysis study. This is line for now effect. This is our effect size. It can be OR or RR. This is confidence interval, which means 95% of confidence interval that we are confident that the number can be between these 2 numbers. Okay, if a study 95% confidence interval crossed over the vertical line, as I showed you, it is not statistically significant. Let me show you here again. If it crossed this line, this is not significant at all. A diamond with a CI line is sometimes presented at the bottom of the forest plot to represent an overall estimate. Like here, let me go back to the previous one. We will have another one with like a diamond shape, and then we will show the overall results from all these 4 studies. Okay, let's go ahead. The blank square may vary in size, reporting the weight of the studies. Let me go back to this one. As you see here, the size for this shape is really low, but the size for this shape is really high. What do you think? Why this one is really low, really small, but this one is really big? Do you have any idea, guys? Any idea? How about sample size? Yes, this is about sample size. Okay, this is about sample size. For example, this study sample size is really low. This one is really high. This one also is high, and this one is okayish. Okay, perfect. As you see here, this is the overall results that we analyzed, by combination of the previous studies. So this is the overall results that we are trying to report and to give the policymakers and the editor of the journals and so on. Okay. Yes, a small study, larger study, and overall treatment effect. This number is like, for example, 0.7. Yeah, as I showed, if this one crossed this line, this is not statistically significant. I already mentioned that what is the effect size? The effect size is like, for example, relative risk ratio, odds ratio, and so on. Here are some advantages for systematic reviews. A really perfect time for comprehensive evidence synthesis. Minimize biases because we are not controlling exposure, or we are not at the risk of selection bias, information bias, recall bias, and so on. Then we are going to identify research gaps. As I said, there are lots of discrepancy between the previous studies, and we are going to address one specific question. Enhance statistical power. By pulling all the available evidences together, we can generate one single estimate for this interested association, and this is really valuable. And generalizability of the data of our data, it's above and far from a country or a small population. It can be like applicable to the whole world. And also time efficiency is another key feature, because as I said, there is really no need to huge budget and so on, and you can simply conduct a systematic review and meta-analysis just by searching the previous literature and trying to make them simplify and generate a result. Okay. In the previous slide, I showed you that. Please remember that Prisma statement. Prisma statement is like this. First of all, identification of studies via databases and registries. Here we have a box about record identified through databases. I mean, Scopus, Web of Science, like Google Scholar, PubMed, and so on. And here it's about other sources that you may reach, okay, by finding in Google or finding in any library or so on. Then we have a total records. Then we will apply our exclusion criteria. Okay, why we are excluding? Because maybe they are not reporting the outcome that we are looking at. Maybe they are, for example, our study is going to examine the association between this risk factor and this outcome among older age patient, for example, about 50 years old. But this study included patients under 50 years old. So this is an exclusion criteria. So we will exclude these patients, these studies. Then we have full text articles. When you are reading full text articles, then this is highly likely that you will also exclude some studies. And this can be related to a wide variety of different reasons. Okay, first here you thought that this record is really may bring some valuable evidence. Then you realize that, oh no, this is not about my target population, or maybe this is a letter to the editor, or this is a review study, because you cannot include a review study in a systematic review. Okay, if you are going to include the reviews in the review, then this is not systematic review. This is umbrella study. This is another scenario, really different scenario. Okay, so remember that you must have to exclude review studies from your systematic review and meta-analysis. This is a really key point. And this is the Prisma statement. Please make sure that you will fill out all the elements in the Prisma checklist that I'm going to show you downloaded from this website. Here, exactly the same as the previous protocol that we had for international studies, like for title, abstract, introduction, method, and also for results discussion and other information that is going to ask us. Make sure that in the interpretation and the preparation of your manuscript is 100% in line with this statement, which is really crucial when you are going to submit your paper to any journal, specifically if a journal is a really high-ranked journal. And finally, thank you so much. I think my presentation is finished, and if you have any question for me, please feel free to ask me. It's my pleasure. Feel free to send me message or your questions. I hope I can write my email here for you. I also have academic email, but I'm not actually checking it regularly. So maybe the best time is just to be in touch with me via this one. If you can see my email address, please let me know, because I cannot send it anymore to you. I don't know the reason actually, because Professor Long is not in the meeting, I think maybe. So thank you all so much. Have a nice day, or I would say have a nice evening, I think, and hope to see you again. Thank you. Bye-bye. Bye.